good afternoon to all of you, and welcome to this Inside St Vincent's event. My name, as Richard said, is David Factor, and I am the former Executive Director of Public Affairs, Media and Communications at St Vincent's in New South Wales, and I'll be your MC and facilitator this afternoon. Some of you may have been fortunate to hear or have watched Kim Williams AM this afternoon, the chairman of the ABC. He did the National Press Club address where he said, "Resilience comes from knowing stuff." Well, I can safely say that today's session is highly likely to build our resilience. Australia is experiencing an ageing population trend, and it is estimated that by 2057, people aged 65 and older will account for 22% of the Australian population. As our population grows older, it is important that we understand how we can maintain our brain, bone, muscle and joint health in order to prevent and manage life-limiting conditions such as osteoporosis, osteoarthritis, dementia and Alzheimer's. Today you will hear from some of our experts working across various areas that align with our theme of brains, bones and balance. Our panel will explore the interplay between brains, bones, muscles and joints, and how we can not only maintain their health but effectively manage our injuries and conditions as they arise. I now have the pleasure of introducing you to our panel. Professor Bruce Brew is a senior consultant neurologist at St Vincent's Hospital, Sydney, and a conjoint professor of neurology with the University of New South Wales and University of Notre Dame, Sydney. He is head of neurosciences research at St Vincent's Hospital and director of the Peter Duncan Neurosciences Research Unit. Professor Brew's research covers dementia and Alzheimer's disease, autoimmune-related diseases, and viral brain infection. Professor Jackie Center is the head of Bone and Calcium Service and the Deputy Director of the Department of Endocrinology at St Vincent's Hospital, Sydney. She is also the head of Bone Epidemiology, Clinical and Translational Research at the Garvan Institute of Medical Research. Professor Center's work has led to her being chair of the Osteoporosis Working Group for the New South Wales Musculoskeletal Agency for Clinical Innovation and joining the American Society for Bone and Mineral Research Task Force on Osteoporotic Fracture and Secondary Prevention. Professor Stephen Foe, AM, is the Director of Pain Management at St Vincent's Hospital, Sydney, and leads the Pain Management Clinic at the newly established AAA Valerie P. McKenzie Pain Management Exchange Program. Professor Foe led the development of Australia's first online free multidisciplinary pain management program in Australia, which was designed to support health professionals and is particularly useful for those struggling with chronic pain who are unable to attend a face-to-face pain management program. Associate Professor Sean Mungovan. Welcome, Sean. He's the Director of the Allied Health at St Vincent's Private Hospital, Sydney. Sean is an experienced physiotherapist and clinical researcher and holds a Bachelor of Applied Science with postgraduate qualifications in exercise physiology. He has an extensive track record in the hospital and healthcare sector, healthcare leadership and sports management. Sean is also a former team physiotherapist for the New South Wales Swifts netball team, and from 2006 to 2011 was the physiotherapist for the Australian Diamonds national netball team. Welcome, Sean. Okay, Jackie, let's pick on you first. What happens to our bones as we age, and just how serious is osteoporosis?
Okay, well, as we age, the bone density declines, meaning that the bones become more fragile and you're more likely to fracture if you fall. And fractures are actually really common. So there's about every 2.9 minutes in Australia, there's a fracture that occurs. And it's not just, we always used to think of it as a disease of older women, but it's actually not. It affects younger women as well, and it affects men. So that if you think about it, 1 out of every 3 fractures actually will occur in a man, and 2 out of 3 in a woman. And it's common. We all know about breast cancer, and for instance, there's about as many women who will die after a hip fracture as will after breast cancer. And that's not accounting for all the other fractures as well. We used to think about fracture being the endpoint for osteoporosis, but actually it's more than that, because the research that we've done suggests that fracture itself is associated with other consequences. For instance, there's an increased risk of having a second fracture, and that occurs once you've had the first fracture. The risk of another fracture occurs about 2-fold. There's a 2-fold higher risk in women and about a 4-fold higher risk in men. And there's also, particularly in older people, an increased risk of dying prematurely after a fracture. The reasons for that we're still trying to understand. But importantly, these risks occur early on, so particularly in the first few years after a fracture. And yet most people still don't think osteoporosis or fracture is important. So we all know it's important to treat heart disease, to prevent cancer, but we know that after a fracture, less than 30% of women and less than 20% of men are actually on the correct treatment.
Gee.
So, yeah.
So on that point, it sounds like early diagnosis and prevention seems to be crucial when it comes to osteoporosis and fractures. So what are the services available at St Vincents for this?
So we've got 2 sort of main services. We've got the osteoporosis refracture prevention clinic, and that was supported by the Yoshiko Wright estate. And we also have our bone and calcium clinic. So if I just mention the osteoporosis refracture prevention clinic first, that's where we aim to target people who've come into hospital or come into emergency or had an X-ray that demonstrates they've got a fracture. Because normally what tended to happen was that they would get the fracture repaired by the orthopaedic surgeon. People would think, okay, that's fine, the fracture's done, leave the hospital or leave outpatients. Then the next time they might go and see their GP might be 6 months later for something completely unrelated, and the fracture would be healed and fixed and that would be it. But there's no investigation of actually their underlying bone health and why they may have fractured in the first place. So we aim to identify people who fractured and then investigate them appropriately and start treatment in those who need treatment.
And as you were saying, in terms of that stigma about it being mainly women, it is a sizable proportion. You said, I think, 1/3 being
about one in 3 fractures, occur in a man.
Gosh.
And it's not just older people; it's actually younger people as well. And often, or sometimes at least, there might be underlying health conditions that are associated with the low bone density. So it's really important that it is investigated appropriately, and then people can be given that we've got lots of good treatments that decrease the risk of fracture.
Right. Sean, our muscles and joints often support bone health, and together they are crucial for balance. Can you tell us a bit more about osteoarthritis and how lifestyle factors can help us maintain bone, muscle and joint health?
Sure. Thanks, David. I suppose there are a lot of people sitting in this room who either have osteoarthritis or have an experience with someone who has had an osteoarthritis. Certainly, you're not alone. You're sitting alongside approximately 3.7 million other Australians who are also experiencing osteoarthritis, and over 500 million people across the world who experience osteoarthritis. And osteoarthritis has traditionally been targeted as just a disease of wear and tear. And in fact, that's just not the case. There's a multitude of factors that will contribute to osteoarthritis. Some of these are genetic factors, some lifestyle factors. A range of different components will come together. Now, the interesting thing about osteoarthritis is, unlike, say, high blood pressure, where you would take a tablet and the disease is modified or is sorted out, cholesterol, there's no disease-modifying drugs at this point in time for osteoarthritis. So all we can do is to manage the degeneration and the decline. The good news story is there are a range of lifestyle factors which can really help you to stop the decline. But there's no silver bullet, and there's no one thing that is going to sort it out. We call these a series of 5 and 6 percenters. So each individual component of these programs will make you probably about 5% better. But if you put 10 of them together, you're going to be 50% better. So the key ingredients that sit around a comprehensive approach to managing lifestyle factors for someone who has osteoarthritis, and osteoarthritis is a broad spectrum of disease. So the key ingredients really sit around key muscle groups providing support for muscles. So these muscles are strong, they cut down impact forces, and there's good alignment within joints, so they're able to exercise well and to be able to move well. So the types of training really are traditional resistance training, like bands, weights, a range of different ways you can strengthen up body weight. But then there's also functional strength training, where you take tasks that you do every day, like squatting and reaching, and you incorporate these into a strengthening program. So when you start to do them throughout your everyday life, they become much easier. There's a core stability component. So having a strong core provides a good foundation for good balance. Balance training itself is absolutely critical, because if you have a fall, it's only going to exacerbate osteoarthritis as a disease process that we look at it now. So we also have a conditioning approach. So people select a conditioning which is comfortable and is safe. So these tend to be lots of low impact type exercise, swimming, cycling, elliptical cycling, a range of different things you can do. But again, there's no one program that's going to suit everybody. So there's two key factors when putting these programs together. First of all, exercise is like garden fertiliser. You put too much on and you actually kill the lawn. So the thing about exercise is to find that balance of how much you actually need. And the good rule of thumb that we use is that when exercising somebody who has some osteoarthritis, it's particularly important that the level of discomfort doesn't move beyond, say, a level of just moderate, like minor to moderate feeling of discomfort. Ever. And if you've overdone it, if you've overloaded the joint, then you've kind of got to work the other way in terms of allowing it to recover. So the second important part is rest. Rest is just as important as exercise. So when you put all these components together, I think supervised exercise programs work really well. Life is not a dress rehearsal, so you want to kind of get it right first go. And it's also, these supervised programs can then go on to independent programs or group-based exercise programs where you get socialisation and other benefits as well. But these will lead into a whole range of factors that will help a range of different body systems, not just, managing your osteoarthritis.
So I know my mum gets a huge amount out of her aqua aerobics. Yep. And actually the point about that is not just the exercise, but the socialisation. Like, she's made some terrific friends. Yeah,
the mantra really sits around do what makes you happy, as the starting point. Yeah, not what you think you should be doing.
Yeah. No, that's a great point. Okay, Stephen, on to you. Pain management is often key to treating osteoarthritis and assisting with rehabilitation from injuries and fractures. Beyond painkillers and medication, what other options are available to patients? And also, Does the brain play a role in pain management?
Yeah, well, that's a great question. The rehabilitation is the sort of end-to-end treatment for osteoarthritis or pain from joints or fractures. And one of the reasons is that you need a whole variety of inputs, as Sean was saying. So hydrotherapy, for instance, works because after a fracture or an injury or severe arthritis, you get pain, and pain often leads to fear. Fear that you're going to cause yourself more harm, or that your joint's going to have further problems, or that you're somehow not going to be able to tolerate any further pain. When you put people in water, you take their weight away, so suddenly the weight that the joint has to carry is dropped away, and if you go up to your neck, it's almost zero. So people can exercise and you can, without pain, and you can strengthen your muscles and all of that in the water. I always have to tell people, unfortunately we are not fish, and eventually you will have to come out of the water. But it's a good way of starting off practicing, and it's a good way of getting your heart rate up. So for instance, a lot of people who are very disabled, who might have had a stroke or severe arthritis, they can't get their heart rate up to keep their hearts healthy because the pain is too severe. So if you put them in water, you can get their heart rates up, they can do exercise, and then they can look after their hearts. So the other thing is, quite often there's a lot of fear of movement and what we call catastrophisation, where people get an injury or they notice that their joint is deformed, and then they develop pessimistic thinking, and they think, oh no, this means I'm going to be disabled for life, I'm soon going to be in a wheelchair, that'll turn me into an alcoholic, I'll lose my house, I'll become a gambler, etc. So the psychological aspects are very important, and by creating a positive environment, and I think that's probably what your mother's responding to, that group where people are encouraging each other, you sort of mitigate against that. So I'll give you a very brief story. There was a woman in our private rehab unit the other day with severe arthritis affecting her hands and her shoulders and her legs, and she had a knee replacement. But she was very slow and couldn't improve, and what we later found out was that she was incredibly anxious because she had a very disabled son. And recovery meant having to care for the son who was non-verbal, and she had to lift him a lot, and she was incredibly frightened of that. And so she was not able to sleep, she was very slow, frightened of the pool. So we analysed that. The occupational therapist talked to her and got her the NDIS assisting services that she needed. We got a psychiatrist in to talk to her about anxiety and how to manage it, and we gave her medication. So that sort of end-to-end treatment for her arthritis is what the addition of rehab is. In terms of the brain plays a huge role in pain, particularly in chronic pain. That's pain that persists for more than 3 months. And what happens is, we know that often there's nothing wrong with the limb. It's not actually deformed or damaged or diseased or fractured, but the nerves are sending ongoing messages to the brain that there's some problem there. And the brain often is unable to assess all of that, and keeps telling the person, yes, you're in pain, that there's something wrong with your leg, there's something wrong with your leg. What we know is that we have this thing called descending inhibition, which is what you use if you're in the cinema and you're watching a film and your bladder's full, but you don't want to leave before you find out who killed the guy. So part of your brain suppresses your need to go to the toilet. So some of the medications, and Bruce will probably talk about some of the medications that work on the brain, actually improve that capacity of the brain to inhibit or stop the messages of pain, at least for a time being. And we use that techniques, psychological techniques and medication techniques to do that. And that's just one part. There's many other parts of the way the brain responds to pain.
Do you feel that people often underestimate the role of the brain? I certainly did. I thought it was just a case of you guys trying to divert our desire for the medication, be it pain management or some of the more chronic kind of medications, but really the mindset and that proactivity is quite critical as well.
Yeah, I mean, it's my favourite organ. As Woody Allen said, it's the largest sex organ in the body. But the truth of the matter is our experiences are very much developed in the brain, and the way the brain interacts with our other body systems is something we're just learning. And I think Bruce will probably talk about this, but for instance, heart rate, breathing rate, memory, our personalities are so enshrined in the way our brains are put together, and our experiences actually form that. So it's a fascinating thing, and that's what research does. It helps us unpick some of that. It's a much more complicated thing than a quantum computer, I think.
Yeah. Bruce, on to you. We've paid a lot of attention about how the body ages and deals with health challenges as we get older. Does our brain age differently to the way our body does?
So usually the brain ages roughly in concert with the rest of the body, but there are exceptions. And the most relevant exception is patients who have dementia or who are at risk of dementia in a subclinical phase. And they're characterised by more advanced ageing, if you like. But there can also be vascular risk factors which may affect, say, your heart, but also can then affect your brain, and then the two can almost go hand in hand. Or even you can have disproportionate ageing as a consequence of vascular disease in the brain without necessarily having the same sort of disease in the heart.
That's phenomenal. Jackie, if we can come back to you, if you've recovered. Are there any likely links between bone health and brain health?
There are actually, and that's something we found out quite recently. Well, we've known for a while that things like hip fracture has been associated with cognitive issues and dementia, but we're finding out more that there's a very close link between bone loss and cognitive decline. So that in fact the more rapidly you lose bone, the greater the cognitive decline, and vice versa, the greater the cognitive decline, the more rapidly you lose bone. And we also have found out that if you lose bone, if there's cognitive decline, it actually increases your fracture risk. So the greater cognitive decline, the greater the fracture risk. And there's probably a whole lot of things that go into this, including frailty, including effects on your muscles, because all the exercises that were mentioned there are actually really good for bone as well. And so I think everything's sort of closely linked, but there is definitely a very close link. The actual underlying mechanism we don't know yet, and that's one of the things we're working on.
It's phenomenal. It's such a kind of a common theme here of that interconnectivity. Looking now to the future in each of these areas, Sean, what is needed to help advance research and treatment in the area of osteoarthritis?
I think first and foremost, I think here at St Vincents we will remain at the forefront of joint replacement surgery. That is done in the private hospital. Joint replacement surgery is interesting because 70% of joints, or 7 out of 10 joints, will be performed within the private sector in Australia. So we have a unique opportunity to provide some research and to contribute to the body of knowledge as well in terms of patient care and what works really well. These services obviously are not new. They've been around since the early 70s. Sister Bernice was instrumental in putting these services together for the private. And we have a world-class facility, so both for not only the surgical approach, but also for rehabilitation as well. But the interesting thing about osteoarthritis management and also research is that we need to have some investment in people who not only have end-stage disease, because the treatment of end-stage disease requires joint replacement surgery. But to piggyback off what we're doing as a high-volume centre, so we do over 1,000 joints a year, is to piggyback off that to help to gain some insight into osteoarthritis as a disease, a broad spectrum of disease. Again, it's no longer a disease of wear and tear, so there's a whole range of factors. And one of those factors is there seem to be some immunological contribution to joint degeneration coming that contributes to osteoarthritis. So the interesting thing about having those immunological pathways is that you've got to have diseased tissue to be able to conduct experiments to better understand what are the drivers of osteoarthritis. So approximately about 12 months ago, Associate Professor Nick Versailles, who's the chair of the Department of Orthopaedics at St Vincents Private, and a brilliant scientist here at the Garvan, Dr. Etienne Marfarquhar, three of us came together and realised that during joint replacement surgery, there's a lot of diseased tissue that's taken away, and it's normally tossed in the bin. So instead of tossing it in the bin, we collect it. And so we have a very experienced theatre team of terrific nurses, amazing. And during joint replacement surgery now, we actually collect this diseased tissue. And that's then transported and it comes down here to the Garvan, where it's processed by Etienne and his team, and it's then banked. Okay, so it's put into a biobank. But what goes with that tissue, what makes it extraordinary, is the patient's story or the patient experience of osteoarthritis goes with that tissue to the biobank. So there are some of our patients who are incredibly stiff before the operation, yet there are some patients who have full range of motion. They both have osteoarthritis, but they both have very different symptoms. So we're able to categorise the tissue, so when the scientists eventually get around to doing these important experiments to work out what are the drivers of osteoarthritis, then we have the tissue to do it, because at the moment there's no biomarker for osteoarthritis. So in healthcare, biomarkers are like a signpost inside your body telling you you've got like the onset of disease, a disease is progressing, or you've responded particularly well to treatment. Some classic biomarkers that we have are things like blood sugar levels for diabetes management. Blood pressure is a good one for how your overall cardiovascular health is going. But again, for osteoarthritis, we don't have any biomarkers. But so some of these immunological pathways could provide some insight into providing us with these biomarkers. So we have the tissue on hand to do it. And an interesting part of our ethos is something that's been drilled into us by the Sisters of Charity, and is that it's really important to immerse yourself into the here and now, but it's also important to think a couple of steps ahead. So Etienne and the team have some great technologies to go down and look at single cells within this tissue. But a lot of the technologies that will help to answer the questions, to find these biomarkers and to find these pathways that could be driving osteoarthritis, these are likely to come in 5 and 10 years' time. So when they do arrive on our doorstep, we'll have the tissue ready to go. So in the last 12 months, we've had about 115 joints that are sitting upstairs in the refrigerator and have been banked for not only the current research program, but for future research program, our future research programs. And we aim to kind of replicate that next year. We have some funding to commence some basic research, but I suppose what is required for osteoarthritis research is investment. And I think the biobank is going to give us a platform for some pretty interesting research in years to come, but it's also a catalyst for some really strong collaboration across the campus. And this is really the campus working at its best, where you've got surgeons, physiotherapists, you've got scientists, we've got rehab physicians, we've got data managers, we've got AI people, we've got our admin team staff members. All these people are going to come together in a really functional relationship across the campus to provide some interesting information. And I suppose what I'm thinking is, can you imagine a time when, if you're in your early 20s and you get the heads up that, you know, through some sort of a biomarker, that your osteoarthritis is starting before you actually become symptomatic? Because earlier identification leads to earlier interventions to try to help you. And you can change lifestyle factors, you can do all sorts of things. I mean, can you imagine a time when there's a pathway that could be identified and that could be blocked at some stage, you know? So you have these disease-modifying drugs. Certainly the quality of life of not only everybody's grandchildren and their children in this room is likely to improve substantially. And I suppose I come back to those 3.6 million Australians and also, you know, hundreds of millions of people around the world. So I think we're really uniquely placed to really contribute something very special because of what's possible on this campus.
And it doesn't sound like it's that far over the horizon, what you're describing there.
Oh, I think scaling these projects up really come with investment, and the investment really comes in sort of developing scientists and retaining them, clinicians as well, developing them and retaining them, but also, you know, competitive government grants, philanthropy, you know, connections with private industry. You know, those are the things that will eventually drive these types of projects to be scaled to a point where they, you know, are incredibly meaningful and life-changing. Yeah.
Absolutely. Stephen, I believe there's been some potential growth and change underway for pain management services at St Vincents, thanks to the generous bequest of the estate of the late Valerie Mackenzie. Can you share more about this?
Yeah, I mean, we're incredibly grateful to the Valerie Mackenzie bequest because it's going to develop pain services across the campus, so at the private hospital but also into the public hospital. At the public hospital, we have a number of services, including an acute pain service. So if any of you break your leg and you get admitted to the orthopaedic ward, you'll see a pain specialist within 48 hours, 24 to 48 hours, to make sure your pain medications are right and that you're not in any pain. And we actually have procedures that we can use in acute pain to get you out of pain with a broken leg almost immediately in the emergency department. We also have a chronic pain service for people who have persistent pain associated with diabetes and a whole variety of other conditions. And we've developed Australia's first online pain management tool because a lot of our patients come from rural areas or they can't tolerate the terrible traffic in Sydney, and they wanted an alternative to face-to-face treatment. So we developed an online pain management program. We did research on it and found it was as good as attending a face-to-face program. And we've sold it to Queensland that are using it there, and for a brief period it went to New Zealand. At the private hospital, we are not as well integrated. The private hospital is a surgical hospital where people come in, get surgery and go home, but a lot of people have pain and the pain can persist. So with this grant, we're hoping to enhance the services at the private so that there's what we call a subacute service. You'll be followed up after you leave the hospital to check that the medications you're on are correct, to check that you're not in trouble, to check that you don't need referrals to other people, to check that you don't need mental health services or any other services. In the public hospital, the bequest will be used to improve some of the research we're doing in online treatments, because I really think the future of pain medicine or pain management treatments will be online and making it easier to access. The bequest has also allowed us to send a scholar to Stanford University, which is amazing, through the America-Australia Association. One of the things that's happening now is we have all an electronic medical record, and that's the government's done a lot to bring that in, and finally Australia will have ours. But what it presents us with is an enormous amount of data, huge amounts of data that we literally need people to understand how to manage. I don't know if you've gone onto a database or people have sent you information, sometimes you can be swamped by it and have trouble trying to work out what it means. So at Stanford, they have a very large database, and we're sending one of our scholars to learn how to manage that database. And then the Stanford people will come to Australia to have a look at our online pain management programs and how to use that. And we think that that collaboration will be terrific. We're also having collaboration discussions with Mount Sinai and the Mayo Clinic and Spalding and a few other hospitals. So I think in the future, understanding how to manage big data, being able to match it with things like Sean's Biobank, for instance, knowing that all the people who had severe pain following joint replacement, what were their joints like? Was there some particular chemical that was present for them and not for other people that could be used to manage their pain? But to do that, you need people to understand data. You probably need people to understand artificial intelligence so that big data sets can be explored. And that's what the Valerie McKenzie bequest is going to allow us to do, to get an exchange on that basis.
That's terrific. You know, what's particularly gratifying to hear is the two-way relationship between us and Stanford. When I first started at St Vincents, it was always one way, you know, these great institutes in the US that we would go over to learn, and it's so nice to see, you know, how much they can learn from us, and that it's a two-way kind of learning like that. It's terrific. Bruce, I want to turn back to dementia and Alzheimer's. Are there any new research findings or potential treatments that offer hope for those affected by Alzheimer's?
Unequivocally. So we're sort of at a phase in Alzheimer understanding and management, which is like MS was in the 90s, where you had good tools to assess the severity, the presence and severity of the disease, and you had treatments that were modestly effective. So that's all happening in Alzheimer's. We have very good tools now to make the diagnosis, and those tools aren't just an amyloid PET scan, but there's also spinal taps. And in the last several months, there's increasing evidence that blood tests, particular blood tests, can diagnose Alzheimer's. Wow. So that'll revolutionise the field when it's rolled out. The tests are not approved by the FDA in the US yet. They're under review. They almost certainly will get approved. It'll make the diagnosis that much easier. They're very, very sensitive and specific. Just to be careful as to what population in which you use them. But there are certainly studies to use those blood tests to see if that might predict the later development of Alzheimer's in a particular population. So marked improvement in diagnostic tools and possibly predictive tools. And then the treatment. The amyloid monoclonal antibodies have got a bit of a bad rap over the last few years. But one of them, Leqembi or lecanemab, is now licensed in the US, licensed and covered in the US, Japan, South Korea, China, Israel. It's approved in the UK but not funded, and the EMA is now coming to approve it with some restrictions. So it's a modestly effective treatment. And what does that mean? It slows the disease down. In the trial was 18 months. You got roughly an extra 6 months, roughly. There have been open label follow-up studies now with patients who've been on the drug for some 3 years plus, and it's a cumulative benefit. So there's continued benefit now. It translates to about an extra year. So that will potentially go even higher the longer the patients are on it. It's not an innocuous drug. It needs to be carefully applied and monitored. And it was knocked back by the TGA here some months ago. It's under appeal. It'll be, I guess, that result of that appeal will be in the first quarter of next year. If it gets approved, then there'll be the funding issue, of course, because it's expensive. Having said all that, it's a step in the right direction. There are lots of other treatments that are also in phase 3 and some in phase 2 that are non-amyloid mechanisms of action, which also look very promising and which in fact may have applicability beyond Alzheimer's. So there's, for example, the end product of Alzheimer's is not just nerve cell loss, but the communication ports, if you like, between nerve cells are disrupted, the synapses. And that's a common disease end product in vascular disease, even in HIV and certain viral infections. It's even in traumatic brain injury. So there is certainly one drug that we're trialling at the moment to see if that can rebuild those synapses. Certainly the data from animal studies are very promising. There are other companies that are also having the same direction of treatment. So if this drug doesn't work, there are others that are in the offing. So it's really quite a revolutionary period.
So when you say potentially rebuilding synapses, are we talking about reversal of degeneration,
Correct.
Not just halting?
Correct. That's what happened in the mouse models of Alzheimer's, yes.
That's phenomenal.
Yeah, it is.
Wow. Okay.
And I'll just point out, there's also a move, so we're part of a study to see if we can predict Alzheimer's with the blood-based biomarkers. And then there are also preventative strategies like vaccinating against Alzheimer's.
Wow.
So that's also under trial, yeah. So.
That sounds like a whole inside St Vincent's on its own. That's phenomenal. Jackie, how do you hope to see our osteoporosis services grow to meet this increase in demand that we're seeing? So
at the moment, we actually can't even reach not even 50% of the people that come in with fractures. So this is not even talking about preventive treatment. This is actually just this is preventing the second fracture, if you like, because that's where the hospitalisations are longer. That's where the injury is often worse. You know, often might get a wrist fracture at first, then the next fracture might be the hip fracture. So it's trying to actually reach as many as people as we can that have the first fracture. The services that we have at the moment, as I said, can't even reach 50%. So we would really like to increase both the physiotherapy time that we have that's associated with the service, because not only are we talking about medical treatment as such, but it's all the other things that Sean mentioned before, bones, muscle strengthening and resistance exercise we know is actually important for improving bone strength as well and bone density, and possibly actually interacts with some of the medication, particularly some of the newer medications. That's a really important part of it. We don't have enough physiotherapist time. We don't have enough even administrative time so that we can try and identify the fractures. Some of this we've done using automated techniques, and that's where all the big data comes in, using the electronic medical record system to try and identify those fractures in a more sort of better time management way. So we really want more time for that. The other is that we know that there's a big drop-off between what happens from the hospital and then what happens later in general practice, that a lot of people don't stay on medication, that we are limited because it's a tertiary hospital in how long we can keep following people up, and we know that the pool of people is growing. So several ways and we've done sort of research to try and identify some of the barriers to the successful sort of integration between the hospital care and the general practice care. The data that suggests that, by 12 or 24 months, only about 50% of people are still on medication, for instance. So that is something that we are actively researching in the refracture prevention services. The other thing that we know is that other associated comorbidities, whether it's cognitive decline, whether it's other disease, heart disease, diabetes, are all associated with, have worse outcomes in people that fracture. And looking at how using the data that we have from the data that we've got plus other data to try and identify how to best treat people with other coexistent conditions, so that you're not just looking at treating one aspect of the person, but you're trying to integrate everything, is also something that we are really trying to do. And we know that there's new medication also for osteoporosis, one that actually builds up new bone rather than just stops you losing bone. But that, of course, makes the treatment paradigm a little bit more complicated, because you need to get the right treatment for the right person at the right time, how to change from one treatment to another. There's some very different transitions and ways that things need to be managed. So it becomes more complex, but treatment is better. But we need to have more people around, more people who actually know about bone and know how to integrate and assess the data.
Terrific. All right, panellists, you've been incredibly generous, and we've gone, I think, a bit over time, to say the least. But if you're okay, we might open up to the floor for a few questions. And just to say, for our viewers online, can I please ask for you to wait until you have the microphone before asking your question, just so it can be heard. But if we can have our first... Anyone's got a question? We've got one. Beautiful. And then we've got... Thanks so much.
I wonder if any of you are using stem cells, or what your opinion is of using the various stem cell technologies in overall of your field, if it's going on here.
Yes. But only in a research capacity. So every person's brain has their own stem cells deep inside, the neural stem cells. They get disrupted in a whole host of diseases, probably by a common mechanism. That's one of the things that we're exploring. So we are trying to increase the neural stem cell pool, because it gets depleted by a number of diseases, and also encourage those stem cells then to divide and develop into specific cells pertinent to the brain. It's clearly very complicated. We use a 3D brain organoid model, so we get inducible pluripotential stem cells, and then they're grown. They differentiate into certain cells, and they form a 3D brain organoid. So that's a disease model. We're sort of getting a better understanding of how neural stem cells work. It's a long way to go, though, before it translates to the clinic.
There's been experiments with stem cells to replace defects in your cartilage. So if you're in a joint, you've got a degenerative joint or an osteoarthritis joint, and you have a little hole there because your cartilage has been taken away. They've tried to grow them outside the body, cartilage or stem cells that'll become cartilage, but the problem is sticking them in the hole. That's the problem. So they tried it, but they keep floating off. They couldn't stick them down with glue because it stopped them from growing down. So I think a lot of people talk about stem cells, journalists do, but we've got a long way to go to work out exactly how to work it. Obviously, it's a very important part of the research. And not to forget that we use stem cell transplants to cure many hematological or blood-borne cancers. So we're using them, but it's still pretty embryonic, I'd say, yeah.
Sean, many people challenge others by saying they should be able to balance on one foot and then balance with the eyes closed. Now, what's a mechanism as to why it's so important to have your eyes closed?
Okay. It's vision obviously always overrides proprioception. What does that mean? You know, when you go into those 3D cinemas and you're on a roller coaster and you start moving, even though you're standing still just watching a movie, because your eyes are overriding what your joints are telling you. So there is a contribution that comes to the joint, from the joint, and that gets even more important when you get up at 2 o'clock in the morning to go to the bathroom and you haven't turned the light on. So you really then rely on that part of the process, that part of the mechanism for your balance and your strength and your control when you don't have those visual cues. So those joint sense positioning, the joint sense can change and decline with age. So it's always good to sharpen that up because, again, having that as well as your vision are two pretty important components to maintain your balance. So it's good to be good at both. Yeah.
And many, many fractures actually occur when people get up in the middle of the night to go to the toilet.
Yep.
I think we had another question.
Thank you very much. My question is really for Bruce. Just wondering what is being done with regard to prevention for dementia.
Yes. So, as you probably know, the Lancet Commission published 14 modifiable factors, and technically on a global scale, for up to 40% approximately of dementia is preventable, and that's all causes of dementia. How that gets implemented in our sort of community setting is very difficult. That's one of the goals that we're pursuing at the moment. But there are some very obvious things like exercise and appropriate diet, Mediterranean diet, and so on. The real issue, I think, is that they haven't been quantified and haven't been really tied to what's appropriate to an individual. That will be one of the aspects that we're trying to look at in conjunction with my colleagues, because there's so much interplay with exercise as appropriate for the individual. And we can also make use of wearables to quantify. I think the key problem with dementia prevention at the moment is that we have the gestalt of what to do, but we don't have the really granular approach that's going to be appropriate to the individual. That's what we're trying to address.
Well, I think Bruce has hit the nail on the head. The delivery of the service is hard. We know what to do, but you get cardiac rehab, you'll get falls prevention, but you don't have brain health programs or brain health clinics. And we know that socialisation, exercise, prevention of heart disease, and even stimulating some parts of your brain to do new learning does slow down and prevent the sudden speeding up of Alzheimer's disease and other dementias. So we just have to reorganise services, and that will take time and a bit of culture change.
There's two types of exercise interventions that work particularly well. So higher intensity exercise can be really helpful, but again, you've got to have the joint health and you've got to be able to do that in a safe way. And the other thing is training with dual task training. So if you walk, say, 20 metres, and then if you then have to walk 20 metres and you have to count back by 7 from 100, people who have some form of cognitive decline, their gait changes quite remarkably. So there's ways in which you can train dual task training, and we do that in our rehab unit a lot, especially with people who have some cognitive decline who are coming through following joint replacement surgery. So,
Terrific. Gentleman at the front.
Sorry, I'm not sure who to direct this to, but how does an injured person access the online service that you're providing for the pain management?
Yeah, a great question. It's available for any practitioner, any health practitioner, so physiotherapists, occupational therapists, doctors, pharmacists, and they go online and they register themselves for free, and then they email you the program. And I think it costs $59 for a year, but if you're coming out of St Vincents, you get it for free because we're mostly researchers to do with that. And it's on the same website as many of the mental health programs, but it's a chronic pain program. It's called thiswayup.org. And you can simply go on that, thiswayup.org.au, and you can get information and show it to your pharmacist or your physio or your GP.
That's phenomenal, and that's totally democratised. Anyone can access that.
Yeah. I mean, you do have to have it prescribed because there's a few, there are some people who've got major depression or mental illness that need to have psychological support, and there's online psychologists that'll support those people, and that's why it needs to be prescribed. But This Way Up also has free programs for the general public, like in insomnia, managing insomnia, and you can just go online and download it.
Gee, terrific. Any more questions in the audience? We've got a lady up there. Thanks so much.
For the joint samples that you've got biobanked, do you have a lifestyle profile that goes with each of those diseased joints so that you can use that as one of the tools to sort of work out, what the variables are within the diseased tissues?
Yeah, that's it's the important part of the most important part of the biobank, and that is the patient's story that sits with the tissue that we have. So we have measures of people's lifestyle. We have measures of their physicality, their strength, how they walk, all these factors, which are their medications, or we get as much information as we can. Next year, we're going to include a dietary component, so what their patient's diet is coming into joint replacement surgery, so we know their level of disease and how that works in relation to what we see with the analysis of the tissue that we have. So we have like these groups of patients like that are categorised, and part of that is an interesting group, for example, is a lot of people will get their cruciate ligaments reconstructed. So a lot on the sporting field, we get a lot of people coming in for joint replacement surgery and they've had cruciate ligament reconstructions. So if you have a cruciate ligament reconstruction, basically 50% will get an osteoarthritic changes and 50% of the people won't. So we've got a group of osteoarthritis people in the bank that we're really looking forward to doing some research on as well. So not only lifestyle factors, but disease factors as well. So as much information as we can. The data managers who manage all this metadata are incredibly skillful people and can manipulate all these parts of the story to come up with some sort of an explanation of what we are seeing from an immunological point of view. Yeah, it's interesting.
That's terrific. We've gone slightly over time, but if the audience is anything like me, I doubt that anyone begrudges our panellists for being so forthcoming. And my goodness, I've been fortunate to host quite a few of these inside St Vincent's, but I don't think I've ever learnt so much. This has been a really enlightening session, and thank you so much